Hello once again, this is Dr. João Flávio Nogueira from Brazil, and we are watching now a movie of an endoscopic middle ear dissection to show the middle ear cavity through this endoscopic approach. So this first part of this dissection is the elevation or the creation of the tympanomeatal flap. This can be done with regular instruments. And then once you open the tympanomeatal flap, you reach the middle ear space. Of course, you elevate the eardrum and the flap of the ear canal along with the annulus, and of course you can go inside the middle ear cavity. We are using for this dissection 3 millimeter in diameter and 14 centimeters in length endoscope, a wide angle endoscope, and then once you reach the middle ear cavity, you have a very good view of the round window niche with its anterior pillar, posterior pillar, the tegmen, and the fustes. The fustes is an anatomical structure that directs you into the round window membrane, which is a very nice anatomical landmark in order to identify the round window membrane. Of course, once you elevate more, you can see the posterior malleolar spine here, which is the home plate of the posterior malleolar ligament. The posterior malleolar ligament is one of the ligaments that suspends the malleus, one of the three ossicles of the hearing. So you have the posterior malleolar spine and then the posterior malleolar ligament, which is a very nice ligament. And this ligament, it's over the chorda tympani. So once you remove this ligament, you can see the chorda tympani nerve. The chorda tympani nerve is hidden in this specimen behind the scutum here. So when you open the posterior malleolar ligament, you can see the chorda tympani going right behind it in the direction of the middle ear. So we are elevating a little bit more the tympanic membrane from the malleus. Of course, this dissection is to demonstrate all the ligaments and all the structures that we can see with endoscopes at the middle ear. And we are elevating the tympanic membrane from the malleus also to open the anterior eptympanic spaces and to open the supratubal recess space. So it's a very big dissection and a very big elevation of the tympanomeatal flap. But this can be done also in surgery. If you want to inspect the anterior compartments of the middle ear and the anterior eptympanic space, you have to understand that you can remove the tympanic membrane all the way from the malleus. So of course this is the posterior malleolar ligament. Behind you can see the chorda tympani nerve, and in this specimen we can see the ventilation roots. Most of the inflammatory diseases of the middle ear starts at the middle ear. They don't start at the mastoid. They happen to be at the mastoid in some cases, but they start at the middle ear because of blockages of the ventilation pathways. We have three main ventilation routes at the middle ear. The air comes from the eustachian tube and goes all the way to the mastoid. In order to pass, in order to make this way, the air has to fly through small zones that we call isthmus. So we have the tympanic isthmus, which is between the malleus, the cochleariform process, and the long process of the incus. We have the posterior isthmus, and we have the anterior spaces that we can find blockages. Sometimes we can have a blockage at the anterior space, and sometimes we can have folds, inflammatory folds that close all these tympanic ventilation routes. So if we have those folds, we can have pressure changes, a difference of pressure between two compartments, and we can have retractions, we can have problems that can lead to other problems more especially. So we have here the round window niche, anterior pillar, posterior pillar. This is the fustes, posterior pillar, and look at this. With this 0-degree endoscope, just elevating the tympanomeatal flap, we can see the sinus tympani. The sinus tympani is a very important structure that most of the recurrences that you have on cholesteatoma is at the sinus tympani or the facial recess. with endoscopes, the endoscopic anatomy of the sinus tympani is a little bit different, and as you can see, we can identify some structures just like the ponticulus, the subiculum, the funiculus, the subcochlear tunnel when it's present, that can go directly to the petrous apex, and of course you can remove disease from the space. The reason that we do nowadays canal wall down procedures is to inspect the sinus tympani, to assure that there's no cholesteatoma at the sinus tympani. But even doing a canal wall down procedure, you're not sure. In some cases there are sinus tympani that are very deep behind the facial nerve, so you cannot see it in a very good way using only the microscope as the main tool for the surgery. So the endoscope is a very nice tool to try to understand this anatomy and to try to see the anatomy that is hidden when you have a microscopic only approach. So you have the facial nerve over there, the incus, the stapedius tendon, the pyramidal eminence. It's a very big ponticulus that you have there. There is the subiculum and the funiculus, and there's no subcochlear tunnel. There's a primitive subcochlear tunnel because the jugular bulb is very high. So you have the cochlear form process, the tensor tympani tandem, the tensor tympani canal over there, the anterior spaces, and the supratubal recess. The eustachian tube. This is a 0-degree endoscope, and with the 0-degree endoscope we can see all those structures. The eustachian tube is anterior over there. So you have the stapes, the anterior crus and the posterior crus of the stapes, facial nerve once again, and the lateral semicircular canal. Once you're doing temporal bone microscopic dissection, you think that the lateral semicircular canal is a mastoid structure, but using the endoscope you see that the lateral semicircular canal is actually a middle ear structure. You can find it using the middle ear as a pathway to the lateral semicircular canal. Of course, we are using a curette to remove a little bit of bone of the scutum, and once you remove a little bit of bone, and as you can see there's not much bone that is removed, and that improves our view a lot. So even with the 0-degree endoscope and even removing a less bone and using only the curette, you see the space that we gain. Of course we have the chorda tympani nerve over there, long process of the incus, the articulation between the malleus and the incus, and sometimes we can see the short process of the incus, and you can understand the ventilation pathways. The Prusak space is over there, more anterior a little bit from the curette, and you have the superior Vromtrauch space and the posterior Vromtrauch space. Those spaces also act as ventilation pathways from the anterior root. So you have to understand this in order to understand the origin of the disease in most of the inflammatory disease of the middle ear. So once you remove this, you can see the articulation, very well the articulation between the malleus and the incus, the short process of the incus, the long process of the incus that articulates with the stapes, and of course the stapes at the oval window. So you have here the articulation between the stapes and the incus, the long process of the incus, and for this dissection we are going to remove the incus just for to show the anatomy that you can see here. Of course, when you remove the incus, you open a lot the ventilation pathways, the ventilation routes, especially the main ventilation pathway, which is from the eustachian tube, passing through the Tympanic Isthmus and going through the mastoid antrum and the mastoid cells. Of course, when you do this, you have a problem of the hearing. You can have an auditory problem because the ossicles together, they are responsible for transmitting the sound that is captured by the tympanic membrane and goes amplifying the sound and going all the way to the cochlea. So once you remove the incus, you can gain a lot of the ventilation pathways. It's like to do a maxillary antrostomy. You open a lot the antrum of the maxillary sinus. In this case, you open a lot the ventilation pathways. But in the other hand, just like in the maxillary sinus, if you do a big antrostomy, sometimes you can have problems. Here, if you remove the incus, you can have you will need to reconstruct if you want to have a good hearing result. So the lateral semicircular canal is there, the facial nerve is there, and can you see a bulge at the facial nerve over the oval window niche? Cochleariform process is there. As you can see, the cochleariform process is a very important landmark and a very important structure that holds the malleus in its place. The jugular bulb in this case is very high, so the hypotympanic cells are not very big, are not very important structures in this case, in this specimen, because the jugular bulb is very high. So we are removing the remainings of the tympanic membrane from the umbus, which is the most difficult part to do it, is to remove the tympanic membrane from the umbus of the malleus. And of course, sometimes you can have tearing of this tympanic membrane, but you can reconstruct during live surgery using perichondrium, using fat if you want, using cartilage. We prefer to use cartilage, the tragal cartilage that you can harvest in a very easy way, in a very easy fashion from the tragus, and of course not creating aesthetical problems or creating big incisions. Actually, it's a hidden incision that you have once you remove the perichondrium and the cartilage from the tragus, and it's a very small incision compared to the traditional post-auricular incision, or even the superior incision if you want to remove the temporalis fascia to use as a graft to reconstruct your defect. So in this case we are using also the malleotomus to remove the head of the malleus. Once you remove the head of the malleus, you open the anterior tympanic spaces better. So you can see the anterior ventilation pathways and the ventilation routes going through the eustachian tube, through the supratubal recess, passing to the area that you can have folds. And the most important fold that you can have in this area is called the tensor fold. The tensor fold is a web, an inflammatory web that can go from the cochleariform process to the cog. The cog is over there at the top. The cog divides the supratubal recess from the anterior tympanic space. As you can see, the cog is there. The cog is the first anterior tympanic cell, so it's a very important landmark, and we are testing this ventilation route. Is open, the anterior ventilation route, and as you can see, the mucosa is different. There is a difference of the mucosa from the supratubal recess and the anterior tympanic spaces. And also this difference is very important to understand the immunological and physiological concepts of the mucosa of the middle ear and the mastoid, of course. The mucosa of the middle ear and the mucosa of the mastoid, they are very important, both in ventilation, gas exchange roles, and also immunological components that they have. So when you destroy this mucosa, when you drill the bone and destroy this mucosa in some cases that otherwise you didn't need to drill, or you would drill just for access of the middle ear, you can have problems in the future because you are destroying, in most of the cases that you drill, normal mucosa. Of course, when you have problems in the mastoid, sometimes you need to drill, and sometimes you need to do a temporal bone dissection, a temporal bone surgery, I would say like this. But in some cases, the disease is restricted to the middle ear, and in most of the cases of the inflammatory conditions, the disease starts at the middle ear. So the middle ear is the birthplace of the disease. So we should always start our surgery, inflammatory conditions in the middle ear, through the middle ear. And the best instrument, in our opinion, to inspect the middle ear and to perform surgery at the middle ear is the endoscope. So the endoscope is a preserve of the middle ear. The middle ear is a preserve of the endoscope. And the mastoid is a very nice structure, a very nice anatomical landmark for the microscope. So ear surgeons, in our opinion, they should learn how to master both instruments, endoscopes and microscopes, to try to provide the best care possible for the patient. Of course, when you talk about inflammatory disease, especially the cholesteatoma, and when you do canal wall up procedures, canal wall down procedures, you have recurrence and residual rates. When we talk about endoscopes in cholesteatoma surgery, in the worst case scenario, the recurrent rates and the residual rates are equal to canal wall down procedures, doing a less invasive procedure. So it's a very nice tool, very excellent tool. This is an angle endoscope at 45-degree endoscope, and we are inspecting the mastoid antrum. As you can see, the lateral semicircular canal, The superior part is the tegmen, and of course you saw the mastoid antrum. In this picture you can see the anterior part, the eustachian tube, and of course using the angle endoscope you can inspect a little bit better the facial recess, which is no longer a recess anymore when you do this endoscopic approach, and the sinus tympani over there. So you have facial recess, lateral semicircular canal, facial nerve, the mastoid tegmen, the mastoid antrum, and the anterior spaces, which is the supratubar recess, the canal of the muscle of the tensor tympani muscle, and the eustachian tube over there. So it's a very nice tool to try to understand, and I hope you have liked this dissection and this understanding of the physiology of the middle ear. So thank you very much.